In this video, what I want to do is I want to walk you through my general approach to a chest x-ray.
For more educational resources, like our medical ID cards, check out medicalbasics.com.
So this case is going to be provided by casestacks.com, which is a website that has a bunch of different cases from x-rays to CT scans to MRIs. So be sure to check them out. I'll have a link down in the description. But essentially what I'm going to do is I've had a video before on just a general approach to a chest x-ray, from the approach of either going from the outside in, inside out, and all of those work well. What I want to kind of talk about in more detail is how I would go through this in a live situation. Before, I had it more of just a static image and what I was looking at. But in this one, I'm going to show you kind of what I'm looking at live and kind of some certain things to look out for. So the first thing that I do is I usually start from the mediastinum, then I work my way to the lungs, and then I work my way to the bones, and I kind of have it in that pretty standard format in terms of what I'm looking for. When I'm looking at the lungs, I'm also going to be looking for effusions and pneumothoraces, which I'll talk about in a second. So first things first is going to be your mediastinum. And so I'll have other videos in talking about all the different lines of the mediastinum, but essentially you just want to make sure all of these are very crisp and they're not significantly enlarged in any particular location that you're maybe interested in. So anytime that you may blur this right heart border or the diaphragm, it may signal you to something that is going to be either in the right middle lobe or the right lower lobe. Same thing with the left heart border as well as the diaphragm. The one thing that I think that people often forget to look at is going to be things like either a left retrocardiac opacity, which would be here, or even a right retrocardiac opacity. So, most commonly a left retrocardiac opacity is going to be something like atelectasis. If you've seen enough CT scans, you'll kind of get the sense of what can cause a left retrocardiac opacity, but other things like infection, edema, aspiration can also blur this as well. So really what you're looking for is it should be see-through. You should be able to see the vessels behind the cardiac space. And so here you can clearly see the vessels, but oftentimes it'll become completely opacified, and very commonly that can be to atelectasis, but there's also many other causes that are going to appear similarly. The same thing can happen on the right heart, and other things are going to be pneumomediastinum. So I always like to trace the border of the heart as well as in the mediastinum, making sure that there's no air that's tracking on. And oftentimes it's very subtle. Usually it's just this thin kind of, almost like you see little bubbles. You see little bubbles that are like maybe a patch of bubbles here, patch of bubbles here, or even going all the way across the heart border, and then also tracking up into the mediastinum and also into the neck. So oftentimes I may not be able to see the actual pneumomediastinum here in the heart. Well, oftentimes what you'll see is you'll see things in the neck, you'll see air in the neck, and then you'll start looking down, and then, oh, I see, there's now an area of pneumomediastinum. I mean, in this situation, that's not the case. This one would be normal, but that's one thing to look out for. The other thing that when I'm looking at this, I'm going to be looking at the aortic knob, make sure there's not a large amount of calcifications, also the wideness of this, and also the size. I feel like oftentimes you're taught looking at the width of the heart compared to the rest of the chest, so kind of having that percentage of, I believe it's 55 or 60%, that is oftentimes, and that's kind of the marker that people use to determine whether it's cardiomegaly or not. That's oftentimes not the most accurate way, because when you look at enough CT scans, you'll realize you would be calling cardiomegaly on many patients that actually do not have it. So it's something that you can use to comment on the cardiomediastinal silhouette being enlarged, but you'll also see when you read more CTs that the reason why the silhouette, meaning this silhouette that we're seeing, that's why we're calling this silhouette rather than actual cardiomegaly. The reason why this silhouette is enlarged isn't always because the chambers are enlarged of the heart. Oftentimes because maybe they have an effusion, or maybe they have very prominent vessels, or maybe it's the inspiration or expiration phase that they're in, and also whether or not it's an AP or PA film. So all these things are going to contribute a lot in terms of you calling cardiomegaly. So that's why whenever you're looking at a scan and you're thinking, oh, the cardiac border and the mediastinal border, they look pretty enlarged when I'm comparing it to the rest of the chest, you can always kind of postulate, oh, is there some degree of cardiomegaly, or is there some degree of, widened mediastinum? But really, you're just going to be commenting on the silhouette being large in relation to everything, but it's not a very specific marker. It's just something that you can kind of keep an eye out for, but that isn't necessarily going to be indicative of anything in particular. So that's kind of the mediastinum, the broad overview of the mediastinum. The next thing you're going to go into is probably going to be the airways, going to be next. Really with this, oftentimes what you're going to be looking for is just, if you have some type of endotracheal tube, or if you have some type of bowing of the trachea, whether it be because of some tension phenomenon or whether or not it's because there's some mass, like some type of anterior mediastinal mass that's pushing against it, that's going to kind of cue you into something. But for the most part, you're not going to be getting all that much from the airways, at least the main airways here. What you'll see farther out, you can see, peribronchial wall thickening. You can see, thickening around the airways, or kind of blurring of these vessels going out farther, and that may indicate, other things like airways disease or edema or things of that nature. So more peripherally, you can really get a good sense of airways disease or pathology within the airways, but centrally it's going to be kind of those main few things. One thing I forgot to mention is before I start with anything, the number one thing that I'm always going to do is I'm going to look at all the devices. So I'm going to look at all the devices and make sure they're all in the appropriate locations. I'll make a separate video in talking about all the different devices, because all of these are, there's many different devices. This one just happens to be, probably some type of right IJ central line, terminating in the superior cavoatrial junction, which is going to be an appropriate position for what we're looking for. But there's many other devices, and I'll talk about those later. You just want to make sure they're all in the same location, they haven't changed from the prior, and that's going to be probably the first thing that I personally look at, but you can kind of look at it in any, in any order that you want. Next thing, after we've looked at the mediastinum, we've looked at the airways, next thing I usually go through is the lung next. And I always start with a pneumo, and I always start with pleural effusion. So the places that you want to look for the pneumo, the first thing is going to be the apices, and these are going to be best seen on some type of expiration view, right? Because that's when the lung is going to collapse the most. When your lung is expiring and the lung is going to collapse, you may see some type of the border of a pleural line either in the apices. You can oftentimes see them in the bases as well, so don't just look in the apices. Oftentimes you'll see some type of pleural line, and then it's just going to be completely lucid. You're just going to see black here. You're not going to see any lung markings. Really what you're looking for, oftentimes people look at it and they think, oh, am I just looking for some type of, opacification up in the apices? I see some type of opacification. It kind of looks like a border of where the lung may be. Well, that's really not what you're looking for. What you're looking for is you're looking for this pleural line for one thing. And oftentimes a lot of things can confuse that pleural line. But in addition, what you're looking for is you're looking for the vessels. So in this situation, if you look, you see all these vessels going all the way to the periphery. That's what you're looking for. You're looking for the vessels to go all the way to the periphery, because really, if you're having vessels past the pleural line or supposed pleural line, that's not going to be a pneumothorax. So really what you're looking for is vessels to go all the way to the periphery, and we see that to be the case everywhere that we're looking at. Okay, so that's typically what I look at when I look at a pneumothorax. I want to give you an example of what I mean by that, and also looking at it in another way. So one thing that I find to be very helpful when looking at these chest x-rays, specifically for pneumothoraces and also for fractures, is inverting the image. So I'll look at it first just in the normal projection. I'll zoom in on the apices, zoom in on the bases, and then after that what I'll do is I'll invert the image and I'll look at it in this other way. And the reason why this is easier is because the pleural line is usually dark, and then the pneumothorax is going to be more bright or light colored. So we'll look at this image. This is a different patient than the one that I was just showing you. And so what I want to show you is kind of walking you through, is there a pneumothorax on this or not? So there's a few things that you might cue in that might make you think there might be a pneumothorax. The first one being on this left side. So you see this line right here, and you might be thinking, oh, is that going to be some type of pneumothorax? And the answer is no. That's just going to be our rib. And if you just look at it right here, if you don't look at anything else, all you look at is right here, it could kind of look like a pneumothorax, right? But we see vessels going all the way across. And also if we trace it backwards, this is going to be the outline of the rib. Same thing with this one right here. If we go on to the other side, we'll still see kind of that same, is that a pneumothorax? I'm not sure. But then when we go down here and we'll follow all this line right here, and I'm going to trace it out for you, we see that line right there, and we're going to ask ourselves, what is that, right? Oftentimes you may look at it and you may think, is that the scapula? In this situation, it's a little bit more clear because we see this, the medial border of the scapula right here, but then we see this other line that really should not be there. When we trace the vessels, our next thing will be is we trace the vessels and we get to this dark line, and I don't see any vessels out here. So that's going to be a situation where this is a pneumothorax. This one's a moderate-sized pneumothorax. It's not huge. It's not tiny. Oftentimes they're going to be much smaller, and oftentimes they're going to be much bigger. So this is just a good example of a pneumothorax and kind of how to go through that process. So going back to our original case, in terms of once I've looked at a pneumothorax, what I'm going to look at next is I'm going to be looking at a pleural effusion. And so really what you're going to be looking for is, blunting of these costophrenic angles. The one thing that is going to be difficult for you, that is going to be true on an upright image, is also going to be true when you look on a lateral. So you always want to look at it in two different planes. But in most situations, or in a lot of situations, you're not given those. What you're given is you're going to be given, a portable supine view. So that you may see some blunting in the costophrenic angles. Sometimes you just kind of see this low level, kind of diffuse opacification, either unilaterally or bilaterally. And, that's just going to be, imagine that effusion is going to go all along the back, right? It's going to go the pleura, in between the visceral and parietal pleura. There's that potential space where the fluid is just going to be collecting, and it's just kind of going to be sloshing around. When they lay down on their back, it's going to go all the way along their back, kind of going up and down. So it's not just going to be dependent in this location. It's dependent here when you're upright, and sometimes when you're like semi-upright, or even when you're down supine. But really, sometimes it's difficult to tell whether or not there's effusion. But really, the simplest way to answer is look in the costophrenic angles and then see if there's any blunting. The next thing you're going to be doing is you're going to be looking at the lungs. The thing with the lungs is look for pneumonia, look for some type of, fibrotic lung disease, look for some type of either airways disease or edema. Those are all things that you can see on a chest x-ray. When you've looked at enough, you'll realize how insensitive or how not specific a chest x-ray is, because this is a slam dunk pulmonary edema. This is a slam dunk whatever it may be, and you pull up the CT and, no, it's actually not at all. It's perfectly normal. So, use everything with a grain of salt, but in this situation, it's a clear, left upper lung zone pneumonia, this kind of dense focal opacification. But the lungs I'll talk about, in a whole nother lecture, because there's a lot to do with the lungs that I can't really talk about just in this lecture alone, but that's going to be one thing. Edema as well is going to be a whole nother topic of discussion after that. Next thing we're going to be doing is going to be looking at the bones. So the bones are going to be very tricky. You'll miss a lot of non-displaced rib fractures. Even displaced rib fractures are going to be pretty easy to miss. But make sure you always look at the clavicles. Make sure you always look at the scapula. Make sure you always look at every single bone and kind of just trace the margin. So what I do is I'll go from posterior to anterior, posterior, anterior, posterior, anterior. I follow every single rib. And if you aren't familiar, these are the posterior ribs, and then these are the anterior. They kind of loop from the back and go forward, loop from the back and go forward. The next thing you want to do is you want to try your best to look at the vertebral bodies, and you kind of play with the window to see if there's any compression fracture. What they'll look like is just you will have lost height between the superior and inferior end plates. They'll just be kind of more compressed compared to the rest. So those are kind of subtle to pick up on the PA or AP view, but those are going to be things that you're going to want to look out for. Clavicular fractures and humeral head fractures are the ones that are going to be the most commonly missed as the vertebral body fractures. And then you never want to miss a rib fracture. Whenever you look for a rib fracture, whenever you see a rib fracture, one is don't get satisfied after the first rib fracture. Always look for continuous rib fractures or multiple, I should say. Then after that, always look for evidence of pneumothorax, because no one ever treats rib fractures. Really what it is, if there's multiple of them, depending on your institution, they may be transferred to the ICU for monitoring of like flail chests and things of that nature. But what they're concerned about is not the rib fracture itself, because that's just conservative. What they're really concerned about, or what you should be concerned about, is a pneumothorax, right? If you have any type of sharp body that's pointing towards the lung, most concerned about is going to be some type of pneumothorax. So always go back to those, major things. The last thing that I want to show you, or the last thing that I'll look at, is you never forget about the upper abdomen. Just like when you look at a KUB, you never want to forget about the lower chest. Whatever you get in an image, you should not just be looking for what you may be concerned about. You always have to look at the other things. And so always look at the upper abdomen, make sure there's no pneumoperitoneum, make sure there's no large mass. You oftentimes will see, renal stones, gallstones. Sometimes you can even pick up, I guess this is more so in a KUB, but hepato or splenomegaly are going to be pretty common. And then obviously pneumoperitoneum is going to be something that is going to be one thing that you don't want to miss. And I'll show you in other videos kind of differentiating between the stomach bubble and an actual pneumoperitoneum. But hopefully this helped to kind of give you a basic understanding of, how I would approach a chest x-ray from the kind of the real-time perspective. In other videos, I'll talk about more specifically all the different components that I was alluding to in a second.
Be sure to check out our website, medicalbasics.com, for more educational resources like our progress notebook, and don't forget to subscribe to our channel for more tips and lessons.